Hello, my name's Kevin Fernando. I'm a GP partner at North Berwick Health Centre near Edinburgh and also Education Director for GP Notebook Education. In this episode of GP Notebook TV, I'm going to discuss the practice-changing DAPA-CKD study, which was published in the New England Journal of Medicine during September 2020. The DAPA-CKD study sought to answer the question, what impact does the SGLT2 inhibitor dapagliflozin have on adverse renal and cardiovascular outcomes in people with chronic kidney disease with and without type 2 diabetes? Now, until recently, we only had evidence that ACE inhibitors and ARBs slowed the progression of chronic kidney disease. During 2001, the seminal renal study published also in the New England Journal of Medicine and demonstrated that losartan, one of the ARBs, reduced CKD progression and also significantly reduced the risk of end-stage renal disease by 28% compared to placebo. However, losartan was not observed to reduce cardiovascular mortality. That same year, the IDNT study also published, again in the New England Journal of Medicine, and also demonstrated that irbesartan, another ARB, reduced the risk of CKD progression and also significantly reduced the risk of end-stage renal disease, this time by 23% and compared to amlodipine and placebo. But again, irbesartan was not observed to lower cardiovascular mortality. However, nearly 20 years later, during 2019, we had the landmark Credence trial published, looking at another SGLT2 inhibitor, canagliflozin. Now, the Credence study demonstrated that canagliflozin slowed the progression of CKD in people living with type 2 diabetes, as well as reducing the risk of both renal and cardiovascular death. Now, the primary composite outcome of the Credence trial was a composite of doubling of serum creatinine, end-stage renal disease, and also renal or cardiovascular death. And canagliflozin was found to reduce this primary composite endpoint by 30%. Now, this was a relative risk reduction. The absolute risk reduction was 4.5%, translating into a number needed to treat of just 22 over 2.5 years. So certainly the Credence trial at that point was the biggest thing that had happened in the world of renal medicine since those seminal trials I mentioned to you, renal and IDNT. So what does the DAPA-CKD trial bring to the table then? Well, in many respects, the DAPA-CKD trial was very similar in design to the Credence trial, but the marked difference was it also recruited people with CKD but without type 2 diabetes. So it was a large, high-quality study recruiting individuals with an eGFR of 25 and above mils per minute and significant levels of microalbuminuria, at least 22 milligrams per millimole. All individuals were stable on a maximum tolerated dose of ACE inhibitor or ARB for at least 4 weeks, so standard of care. And again, these were individuals with and without type 2 diabetes. About 2/3 of the DAPA-CKD population had type 2 diabetes, 1/3 did not have type 2 diabetes. And these individuals were randomized either to receive dapagliflozin 10 milligrams or placebo. Now, the primary composite endpoint of DAPA-CKD was a composite of a sustained greater than 50% reduction in decline in eGFR, end-stage renal disease, and renal or cardiovascular death. There were also some secondary endpoints of note, including hospitalization for heart failure and all-cause mortality. So what did the DAPA-CKD find? Well, actually, the DAPA-CKD was stopped early because of an overwhelming protective benefit of dapagliflozin observed in both people with and without type 2 diabetes alongside chronic kidney disease. And what they actually found was a 39% relative risk reduction in that primary endpoint. This is equivalent to an absolute risk reduction of 5.4%, which translates to a number needed to treat of just 19 over 2.4 years. So another very compelling reduction in significant adverse renal and cardiovascular outcomes. So, as you can see from these results, this is an intervention that can potentially have a significant impact on both quality and quantity of life of people with CKD, with and without type 2 diabetes. Now, there were also some very interesting secondary endpoints, as I mentioned. One of them was all-cause mortality, and actually dapagliflozin was uniquely found to significantly reduce all-cause mortality by 31%. Again, the absolute risk reduction was 2.1%, translating into a number needed to treat of 48. So canagliflozin in the Credence trial did not demonstrate a reduction in all-cause mortality. Neither did some of these seminal ACE inhibitor and ARB trials. So quite a unique finding there. And again, significant impact on quantity of life in people with CKD, both with and without type 2 diabetes. And finally, what about the safety profile of dapagliflozin in this population? Well, overall, a very reassuring safety profile, which is great from a primary care perspective. There were no differences observed in lower limb amputations. This has been highlighted as a potential adverse effect of SGLT2 inhibitors in the past. There were no episodes of DKA observed, actually. Again, this has been noted as a potential complication of SGLT2 inhibitors in the past, and we've had a couple of MHRA alerts about this. And there was no imbalance in hypoglycemic episodes, dehydration, or acute kidney injury. So overall, a very reassuring safety profile. That certainly tells me that the risk-benefit ratio remains positive for the vast majority of people living with type 2 diabetes taking an SGLT2 inhibitor. So, to conclude then, practice-changing trial DAPA-CKD, and along with the Credence trial looking at canagliflozin, this is going to have significant impact on the future management of people living with CKD with and without type 2 diabetes. So certainly two of the biggest studies that have happened in the renal world since the advent of ACE inhibitors and ARBs. So thank you for listening, everyone. I hope you found this GP Notebook TV episode helpful.